Awesome. So I'm super excited to be talking with my former residency colleague, 1 year ahead of me, right, Mark?
Yeah, I think so.
Mark Zeitzer. We were at residency together, emergency medicine, Jefferson. So Mark, welcome.
Thank you. You say that I was a year ahead of you, but I feel like you were light years ahead of us because you figured out a path out of clinical medicine very quickly. You've also made a lot of astute observations about, burnout in medicine and how few of us who were in residency together are still practicing emergency medicine. Kind of scary.
It is scary. Actually, the person who left the fastest was Brian Rudick. I think the day after residency ended, he was already done.
Smart.
Yeah. So Mark, tell us, give us first an overview of your path and your journey post-residency.
Yeah. Okay. So after residency, I was a chief resident and I got to stick around at the residency program, which was really fun, and got a little bit of experience in what an academic medical center looked like. I think the most powerful thing that I learned during that time was we had a yes man boss, and you don't want a yes man. So a yes man will tell you yes to every request, everything that you want to do. It never tells you no. But then as soon as you close the door from that meeting, he turns around and tells somebody else yes, and it's in complete conflict with what you've just agreed to. So nothing ever happens, and everybody just gets really frustrated. So I stayed there for about 3 years, and then I had one kid at that time, and we always wanted to get back to the West Coast, and we saw an opportunity to move to Oregon. And so we moved to Portland, Oregon, which was fantastic and beautiful and wonderful. And of course, we arrived in June, and the summers in Oregon cannot be beat. If you visit Oregon, you want to go from July 5th until the end of October. It is just spectacular and beautiful, and there's not a ton of bugs. Which is really nice. And we started our life there. I was working in a rural emergency department in Silverton, Oregon, and I loved it. It was great. The acuity wasn't crazy high, but there were times where we get 2 or 3 trauma patients all at once. We were level 3 trauma. It was single coverage overnight. It was very efficient and fun. I never really felt like, oh God, am I gonna burn out, or this is terrible. I did see some things that were frustrating to me, we had a lot of migrant farm workers in that community, and in that culture, what tends to happen is as soon as a kid gets a fever, they bring them into the emergency department because that's really their only resource, and that's how it was back home. And so it was frustrating seeing all those patients and getting the waiting room really crowded with that kind of stuff. And we saw some people get triaged differently based on that, which really wasn't fair or right. But I reconnected with a friend who had just gone to work for a really cool, interesting company called ZoomCare. He was a family practice doc, and they were trying this model that was urgent care, but also more anything that you needed from the medical system on a daily basis. And they were there for you, and they were also appointment-based. So, busy young family, get in at 12:15, get that ear infection taken care of, getting that sore throat taken care of, getting that depressant medication taken care of. So we would go and have a beer and talk about cases and think about things, and we started realizing that there was this tension out there, because I was working in a rural emergency department, and every time they had a patient who, they being ZoomCare, had a patient with a swollen leg or right lower quadrant abdominal pain, they had to send them to the emergency department. There wasn't anything that they could do with them, and I was sitting there getting frustrated in the emergency department with all these lower acuity patients, and what could we do with this group of patients that was in between the emergency department and urgent care. And so in 2012, we started thinking about this idea formally, and like, could we build something that could take care of those patients? In 2015, we launched what we call ZoomCare Super. Think of like Super Kmart or something like that. It's got groceries and it's bigger and it's shinier and fancier. These are facilities that have about 9 rooms. They're run by emergency physicians. They're open extended hours, anywhere from like 8 a.m. to 10 or midnight. And they have a CT scanner, and they have X-ray, and they have ultrasound, and they have a full lab. You can give IV fluids and medications. And sometimes you do diagnose people with emergencies or things that need surgery right away, and we get those patients admitted to the hospital. And we now have 3 of those clinics, 2 in Portland, Oregon, and 1 in Bellevue, Washington. They're doing well, and it's really fun to work those clinics. And those of you who have a management bend are hearing all the different things that we have at those facilities and realizing they're very difficult to staff and keep staffed. Each day is a new adventure. But today we're saving our patients and the payers about $13 million a year, and probably close to 30,000 hours when you look at patient time for chest pain, abdominal pain, orthopedic injuries. We've taken the data from local emergency departments, and we see how much they charge, and we see how long patients stay in those departments. And there is real savings. And our patients love it. They love scheduling their emergencies. They love having that resource there and having an alternative to the emergency department. So I helped run that, and I remember maybe 2 weeks or a month in, and me and this other guy were doing all the shifts and seeing all the patients. We went to the founders of the company and said, so when do we start to get some administrative time to do all this? And they must have been laughing to themselves. They were very good with us, but they must have been laughing to themselves, saying, who do these guys think they are? 4 weeks in, saying, all right, now I need a couple of days a week to run the place. We were right. We did need that time, but it just wasn't there because we weren't seeing enough patients. And slowly over time, I took on more and more responsibility. Probably somewhere around 2017, 2018, I became the medical director for acute care services. So all of our urgent cares, our super clinics, anything else that was more acute care associated. And then in 21, I became the chief medical officer of ZoomCare. And that has been a ton of fun and a lot of work. And I continue to do that today.
Wow. So are you guys just billing fee-for-service urgent care, or is there a different business model?
Yeah, so these are great questions. And this is sort of where we've messed up and where we've needed to pause and think about this in a different way. So we don't bill as urgent care. We actually bill as primary care across all of ZoomCare, which is crazy because the insurers don't understand how we're billing primary care, but also billing for a CT scan and billing for ultrasound. Right. And so we have now gone to the insurers and said, hey, here's the data. Look, we're saving you millions of dollars a year. We're saving your patients thousands of hours. We really need to be paid differently because the current model isn't sustainable. And that's what we're going to bat for right now.
I see. And so those talks are ongoing.
Ongoing, yeah. And it's a totally unique system. Like I've been working on my elevator pitch on this for years, but it takes a while to explain, right? There's not like a recognized specialty around this. There's emergency departments, there's urgent care centers. There's nothing like an urgency center or a high acuity urgent care. So it is really defining a new product.
I've done a moderate amount of work in the kind of ED avoidance space, and the hardest part when you're pitching the payer on these sort of models is proving the counterfactual, right? Like this person would have gone to the ED, and maybe 10% likelihood they may have even been admitted or gone into obs, and it would have cost you that much, right? So I saved you X amount of dollars. And they kind of raise their eyebrows and like, I don't know, right?
That's always the problem with the payers. They hold all the cards, right?
Yeah,
And so, when we go to them and talk to them about, look at all this access we can provide,
right.
they're not all that interested. So what we did, and what we've been fairly successful with so far, is just taking apples to apples. We said, okay, let's take X emergency department and let's take all comers for chest pain. Let's take our super clinics. Let's take all comers for chest pain. And, in fairness, those patients are very different patients. The patients that are going to an emergency department with chest pain are typically higher acuity. And we discharged over 99% of our chest pain patients. So it's lower
Wow.
acuity. But the insurers also love to hear that we admit so few patients.
So Mark, was this super idea your idea, or kind of?
I had a lot of help. It was a great team. But yeah, I like to think that this is something I came up with.
Wow, that's really amazing. So when you embarked on this path, were you thinking, oh, I'm going to create this like, CMO path or role for myself, or were you just trying to solve a problem?
Oh, yeah. I, in my wildest dreams, I was not going to be the CMO. In fact, probably 6 months, maybe even 2 weeks before I became the CMO, I was like, I don't want to do that job. I felt like the guy who's running for president, who's saying, I'm not going to run for president. Yeah, it was all about solving that problem.
Interesting. And so what have been some of the most challenging aspects of this role?
So many. Throughout this time, we had COVID. That was very challenging, very, very difficult. I think that consistency in medicine is really hard and frustrating. And I don't mean to begrudge our employees in any way. They're a very talented group of people, and I have learned so much from them. But getting one doc to practice like another doc, like another PA, is very, very difficult. And also getting people to read things, whether we're talking about employees or patients, gosh, that's hard. And hey, I'm guilty also. But people don't read policies. They don't read instructions, and oh, that must not apply to us because we're this kind of clinic. Oh, because we're on the south side of town. And you walk in a clinic, and they're doing something that you just told everybody not to do, and they have no clue about it. It's frustrating.
Wow. Wow. It reminds me of some of my work at Optum. Folks think that Optum, is like being the largest medical group in the US is like one big conglomerate all rowing in the same direction, but it's not. It's really like all these fiefdoms, all these individual medical practices. And I was on the national team, so it was, my team's job to come up with these new workflows and protocols and try to get all these fiefdoms to play along, and it is a nearly impossible task. How do you influence like behavior change at scale? It's one of the most challenging things in healthcare, I think, is like
absolutely.
implementing this sort of stuff. So how did you learn along the way all the things that you needed to learn as a CMO? Because obviously it's more than just clinical.
Well, first of all, I didn't. I'm still learning, right? I think that I don't have a business degree. I thought about getting one. I feel like, and we'll see where my next adventure takes me. I feel like I've gotten the MBA in a trial by fire, but we'll see what other employers think about that and look at that. I think that one of the biggest things that I have done is that I've always been very empathetic to the provider, right? if someone, if there's a patient complaint and it involves a narcotic, a benzo, that's not a patient complaint. That's something different. We're going to talk about that. I'm going to be very empathetic with you, but you know, you're our provider. We want to support you. We want to make sure you feel good about the hard work that you're doing every day, and some of the nonsense that happens around controlled substances and things like that. We need to separate that out. I approach things with humility, with humor, with enthusiasm, and I get it. Like I've been there. I do it. I continue to do it. I understand the frustrations with the EHR and the frustrations with the patients. And also, let's celebrate the wins, because we can focus on the negative stuff. But gosh, there's a lot of good stuff that happens. Our super clinics, when you look on Google, have a 4.6 out of 5 stars, which you just don't see in medicine. And when you look at our NPS scores, usually high 80s, or excuse me, high 70s, low 80s across our 43 clinics. These are things to be very proud of. Our patients love it, and our providers deserve to feel good about that.
Yeah, NPS scores that high are incredibly rare. Like you only see that with like Apple and like Disneyland. Yeah.
I like to say, I've looked this up, Disneyland in California, they have like 50,000 reviews, but they're only 4.5. We're 4.6, and we put needles in people and do painful procedures. So there,
That's
better
amazing.
than Disneyland.
So let's get into like some of the nuance here. You said you're a strong advocate for the providers, but as you go higher up in the ranks, you have to also then keep in mind the business interests, the interests of the financial stakeholders or equity holders, and sometimes there's friction between their interests and what the providers want, right? So like, how do you balance that? Maybe what are some things you've learned or some challenges or mistakes you've made in that role?
Yeah. It is a really good question. There's subtlety and nuance to this. I think that ultimately it comes down to no money, no mission, and that is at some point going to come down to a conversation with you and a provider, where a provider is saying you want more and more and more out of me. You want me to see patients faster, and yet I need to make sure that the patient is safe. You all are just run on profits, and you need to make a good argument that that's not true, and make sure that that's not true. So my approach is, yeah, I want to be a provider advocate, but I don't want to just come to the executive team and say, hey, executive team, our providers are seeing 27 patients a day in a 10-hour shift, and it's not safe and it's not fair. I need to come to them and tell them why and what we're doing wrong, what we're doing right, how we can refine that down, and make sure that patient safety remains number one. And I then need to go to the provider and say, hey, I get it. It's hard. Where are you getting hung up? What are the things that are keeping you from doing this? And how can I best support you? What tools do you need? Okay, you're seeing 27 patients a day. Why are you in the clinical inbox at all? You're producing at a very high level. Let's clear that stuff out of your way so you can focus on the patient in front of you.
Amazing. So what does a typical day look like for you when it's a non-clinical day?
So I typically get up early in the morning. It's just the way my brain works, and I make a cup of coffee, and I get to work. And that's really when my brain is working the best, and I'm able to really move through things quickly. So lots of email. I do use my email as a to-do list. They say that's a bad thing to do, but that's what I do. It seems to work for me. And that's when I do a lot of my document reviews and looking at different spreadsheets, things like that. Try to get an exercise in. Exercise has become more consistent and stable for me as I've moved up in my career and been able to say, nope, I need to reserve this time for this. So I try to work out 4 to 6 days a week, depending on the week. And then meetings start at 9 a.m. And I typically in meetings, pretty much the entire day, which is awful. And something that I need to change because you got to get work done, and you can't get work done when it's just like meeting after meeting after meeting. A couple of days a week, let me say a couple of days a month, ideally once a week. I'm in clinics, I'm talking to providers, I'm at the elbow with them, seeing how it's going. I try to bring treats when I go in and see the providers, try to bring some appreciation and some things for them to feel proud about, help them feel good about what they're doing on a daily basis, because it's hard work and it's really important work. It makes a difference. I take that phrase from Mel Herbert very seriously: what you do matters, and try to spread that with our providers. Yeah.
Keep going, sorry.
And then I'm lucky because it is a hybrid. I couldn't work at home by myself all the time. At this point, I'm only doing 1 shift a month, seeing patients. I really enjoy it. And it also keeps me in it and makes me legitimate to my providers. And then our executive team gets together at least once a month in person. And we have our board meetings as well, which are important in person. And so I feel really blessed that it's a nice combination.
I love that you said that you bring treats for the staff. I remember I was moving from working in one ED to another, and so I'm walking into Sibley ER in DC with my starched white coat for the very first time, and I walk in through the ambulance entrance, and these 2 nurses who are seated and talking to each other, they kind of turn and they look at me, and one of them says out loud, so the whole ER could hear, "Who the F does he think he is?" And I knew these 2 are like the tastemakers of the ED, and I had to get them on my side. So the next day I came with a big box of cookies for them, Linda and Janet, and they became my best friends. And I had a wonderful career in that ED. But yeah, you got to feed the staff, 100%.
Absolutely. Yeah. This is how we make friends.
Amazing. So as you think about kind of where your career goes in the next 5 to 7 years, like how do you even approach this? Like, what are the things that matter to you? How do you approach this differently now than kind of how you, up until now, it was mostly like it just kind of happened in a certain way, right? But now that you can be kind of deliberate about it, what are the things you're thinking about?
You've caught me in an early phase of this. And so I'm going to think out loud a little bit. So today, at most, I was over 4 states, Oregon, Washington, Idaho, Colorado. We had 63 clinics and 200 providers. And that was a lot of fun. And it was also really interesting looking at it at that scale. So I want to continue to scale myself in that way. As a medical provider, I can go see 25 patients in a day, or I can see 1,000 or 2,000 or 10,000 patients because I have this team of medical providers that are out there and really helping contribute to the health of our communities. So I am at a crossroads. I'm thinking, do I want to go more traditional and become a CMO of a hospital or a medical group and do something that's less entrepreneurial, less innovative? One of the very sad things that I've learned is that innovation is especially difficult in medicine. There's really good reasons why everybody does it this one way, and why the big players in the EHR space are set up this way? Or do I want to go and do something, again, more entrepreneurial, and something that's just burgeoning? And so these are the decisions that I'm going through, and a lot of it comes down to timing and opportunity.
So, Mark, when you overseeing so many clinicians, I'm sure that you see some who have great potential to become kind of the next batch of medical directors and leaders. So what are some of those signals that you pick up on?
Absolutely. So not any insult to our folks out there who have worked really hard to get masters in healthcare administration, masters in business administration. The business side of things is hard, but there is some intuition to it. The business side of things can be a little bit more easy to look at. And when I see a provider who really gets it, who understands that things need to add up and make sense, and where their role is in it, that is somebody that I really think, oh, wow, that's somebody that could make that jump. And I think emergency medicine does a great job of helping prepare us for this, because we have that opportunity to make decisions on an ongoing basis with incomplete information. And that's a special and unique and difficult skill. And I've seen a lot of ER docs be really successful in that way. And then, there's different folks that fit in different places. So there's people who are policy experts, or writing those policies, and getting in there, getting passionate about it. I have a provider who is really inspired by, of all things, occupational health. And the thing that she's really excited about is that it's so painful, right? And it's such a hard thing that when it happens within the institution and outside the institution. So she said, look, I'm going to work really hard to make this as easy as possible for everyone. So she has that passion on that policy side. You see other providers that are excellent billers. And then you see the rare provider that's not only an excellent biller, but they also want to help teach and educate and push back on the billing department to say, hey, that's not how I understand it. And are we sure that we're not cheating ourselves by doing it this way? So it's fun to see folks who have really specific talents and interests. One of the unique things that we've done at ZoomCare is we've elevated our APPs into leadership roles. You don't see that very often, but with so many clinics, we have to divide it out. And so having APPs that are close to the work and do the work, but then can also help providers get better, get faster, deal with patient complaints, has been a really powerful and enabling force.
Amazing. So in our final minutes here, what sort of thoughts or recommendations do you have for folks who are earlier in their career and just starting to think about creating a path towards some sort of leadership or executive or business role?
Yeah. My advice is to get really good at something. And don't do it with that goal in mind, but do it with the goal of being really good at something. So, being really good at patient care, being really good at efficiency in the emergency department. If you're an ER doc, and when you come on shift, the nurses are saying, who do you think you are? And, oh gosh, it's Dr. Zeitzer again. This is going to be a long one. There's a bigger problem. What can you do to break down those barriers and be the doc that, like, oh, Dr. Zeitzer's coming on tonight. It's going to be an awesome shift. We're going to move through a lot of patients. We're going to take great care of people. We're not going to sit on things. And so when the hospital administrators come down, they're going to point at you and say, this is the person who really understands and is able to clear things out of the way versus the person who's just collecting issues and problems.
Amazing. Mark Zeitzer, thank you so much. Really appreciate it.
Thank you. What a pleasure.